talking about, just reviewing some aspects of health service research and person-centered medicine. And I will provide a description of what are we missing, what are the problems we have, what we are doing in our team, and if I have enough time, some other examples. I talked these days about all this umbrella area of collaborative health, where we have person-centered care, integrative medicine, integrated care, chronic care, complexity and health system research, bridging and knowledge transfer, health ontology. And what concerns us in health service research is the link between person-centered medicine and care and complexity and health system research. And we have to take into account that when we do a literature search of this area, what comes as the main topic is not person-centered health or person-centered medicine, but person-centered care, understood as the design of patient care where local resources and personnel are organized around patients rather than around specialized departments, and then person-centered planning, a written care program designed for a particular patient. And we have similar concepts in public health and at a population level in people-centered care and planning. If we look at the available literature in person-centered care, we see a steep increase since 1993, and the main areas, the main headings in this field are related to patient satisfaction, the doctor-patient relationship, etc. But we have quality of healthcare as one of the key topics, and one of the journals where we have more papers on that is Health Affairs. And in person-centered planning, we see that it's an area that has been going on for a longer time. There are more papers in person-centered planning, but we see a decrease in the last years in relation to the increase of person-centered care. What do we need to generate evidence in health service research related to person-centered care? We need good context information on legal policy plans. We need to know the philosophy of care at area and territorial level. And there are several models of philosophy of care apart from the person-centered health approach. We need indicator sets related to person-centered health. We need the description and the mapping of the services and programs available at local areas, at meso level and at macro level. We need information and comparable information on provision and accessibility of services. We need to know the quality of care, the implementation, and we should carry out impact analysis of what are these person-centered care approaches at these three levels. We need to know more on benchmarking and efficiency, and of course we need to know the financing aspects related to the funding flows, payment mechanisms, incentives, and barriers to person-centered care. And we have several instruments that allow us to understand the philosophy of care from a person-centered care perspective. Either some instruments that assess the interprofessional collaboration across different levels of care, primary care, specialized care. We have questionnaires that assess patient assessment of chronic illness care that incorporate patient-centeredness, the patient activation measure, the EMAC, or the assessment of readiness for chronicity in healthcare organization, or other instruments as the one presented here, the person-centered care index. These instruments really provide us with a tool to understand what is the philosophy of care, either in a facility, in a local area, in a county, or in a country. But what are the problems we face? We have five major problems. The first problem is a problem of commensurability. It is impossible to compare like with like in service research. And we have many examples in aging, in mental health, in long-term care, where when we try to compare service provision and delivery across country, we find that we are comparing very different things, even when we are talking about the same names. Daycare centers do different things in the very same city. So saying that this region or this country has 200 daycare centers means nothing in comparison to what we have in another area. So we cannot use that for comparative priority setting. We have also a problem of transferability, a difficulty to transfer the information across territories. We have a huge terminological variability in service research, and we have a problem on our focus. Our focus is mainly on efficiency, good practice, and benchmarking. And as it was said before, the problem is inefficiency. The problem is how we assess inefficiency. We have a lot of tools to identify a benchmark, but we have very few tools to understand that inefficiency that is behind the efficiency level. And then we lack a standard indicator set. What are the alternatives for these challenges? In relation to commensurability, we've been studying services around European countries for the last 15 years. And we reached the same conclusion that other researchers, that it was not possible to compare service delivery and provision using the traditional names. So we had to develop a new unit of analysis to do these comparisons. And it was the minimum organizational unit with temporal and organizational stability. And we call it the basic stable inputs of care, or BASIC, and we have defined it formally and operationally. In relation to the transferability, we need an international coding classification systems of the main types of care that allow us to understand how these services are delivered in one country in relation to the other. And we develop another operational label or coding for that. It's called the MTC, or main types of care. We need glossaries of terms, and we have developed one. We need to focus on technical inefficiency and not so much on efficiency. And we need new listings of indicators that are related to the person-centered care model, such as the patient-centered health indicator review, the NHS indicators for quality improvement that incorporate person-centeredness, or indicators of person-centered care in Canada. We have several examples of how this can be followed. So we have been using this system to overcome the problem of commensurability and transferability of services. And we have used it for providing comparisons of service delivery across several European countries. We have published several papers on that, mainly in the mental health area, but also in long-term care. And now we are running a study of the financing, the mapping, and the continuity of care, of mental health care in 9 European countries in a study called Refinement. In order to do that, and of course I'm not going to go in detail in that, we need a taxonomy of the micro-organization of care. We need to know what are these components, and what we found is was that when we identified these basic stable inputs of care as a stable microorganization unit, there were other things in the facilities that were not that, and we needed to know them as well and how to classify them in order to have exclusion criteria that identified what is and what is not a basic. So we have understood and developed codings for other continuous inputs of care that are not stable, for the stable inputs of care that are not stable from a temporal point of view, the programs, and other types of organizations in the facility. And doing that, we are able now to map what is happening at the facility level and aggregate it to know what's happening in small health areas, in health districts, in regions, in countries, or at international level. This is the taxonomy we have developed in Europe to describe the main types of care that allow us to sort out the problem of transferability of the information in Europe. So what we provide is a coding system, and we are not using day hospitals or the traditional wording for describing these services. And this allows us for actually provide comparisons that are useful for priority setting and planning at European level. And the system works like a alphanumeric system where we have a code that identifies the target of the service, then an alphanumeric identifier that is used in computer databases, a descriptor of the activity, for instance, the code 02.1 is outpatient care, acute, home and mobile, 24 hours availability, and health related. And then we have the label of the system that we use for developing the visual tools that we provide to politicians, and a qualifier of the system. And for instance, this is the analysis of residential care for mental health, including health, social, education, employment, and crime and justice services for mental health in the 7 health districts of Catalonia. And we see where there are the difference. We can provide it to the policymaker, and the policymaker can take decisions. For instance, there is one of the regions that lacks acute hospital care in Catalonia, while the residential care provided by the social services is high. So a guidance for the integration of care can be provided using this system, and we can compare that. We have the data now to, for instance, other regions in Spain, like the Basque Country or Catalonia, the Basque Country or Madrid. And in Spain we have 17 different systems that really work in a completely different way, and we are now comparing them in 9 European countries. We are also carrying out a comparison of Spain and Chile. And then we can use this information to do more detailed analysis. We have at the right side of the slide the geographical information system analysis of hotspots and cold spots of mental health problems. That means these areas where we have an unusual high level of mental health problems or depression or schizophrenia or whatever, in relation to areas that have an unusual low level of this pathology. And this low and high level appearance of a problem are related. So we are studying these relationships, and we are comparing them with the availability of services. So we are sure that it's not related to the availability of a psychiatric hospital, of a high level of a community mental health center in the area, using the other system. And we are using it as well to do an analysis of the technical and inefficiency of the 72 small health areas of mental health in Catalonia, and we can rate them and identify the level of difference in relation to the benchmark. And we have published this recently. This was part of an European project and is published in EuroHealth 2011, and it's available online. So we have now a system that can provide 2 of the aspects of the problems we have in health service research, in person-centeredness, that it's transferability and commensurability. We have other approaches, and I think the current developments at the International and the Institute of Health Improvement in the United States that was presented at a recent conference in Berlin, the conference of the International Foundation of Integrated Care, do provide us with other part of information, that is the use of new technologies and how we can incorporate narratives to the analysis of services at country level. This is a very interesting program called the Conversation Project. It is a project to expand in the US the habit of talking about death at family level. So anyone can say what are his or her preferences in relation to the last days of his or her life. And this is a very interesting program that it's working at national level with a high impact in the total visits and people who are using this program just to make other people, our family, our doctor, know what are our choices in relation to the end of life. The other fascinating program that was presented at the International Conference on Integrated Care 2 weeks ago was in relation to another program by the Institute of Health Improvement that's called Improve Care Now. It's a program to transform health care and cost for all children and adolescents with Crohn's and ulcerative colitis. And this is a very interesting program because it has incorporated social networks where kids just communicate one to the other and they just provide counseling to peers. And this has improved significantly the level of health of these kids with Crohn's disease. So we have new alternatives that are outside to the traditional models that we have to incorporate in the analysis of health services in relation to person-centeredness. Thank you.